Right. So currently, there's always potential for mistakes when we're downgrading from one level of care, acute care setting in the hospital, going back to the patient's home. And, I have my patients, they're discharged from the hospital without the doctor or case managers ever talking to the decision maker children, and which is terrible. And so often mistakes are being made and they're not following the discharge plan that was set up by the physicians at the hospital. So we're intervening, right at discharge, either in the hospital or within a day back at the patient's home or wherever they're living, their boarding care, their assisted living, and making sure that all of the orders are being followed and the new medications are being followed from the hospital, such as antibiotics for a certain period of time, or Lasix and potassium, those type of things that are so critical to avoid a patient going into another crisis, and then making sure that those critical follow-ups with the PCP and with the specialists are being made, because oftentimes those things just fall through the cracks and the patient doesn't have the support of children. They're home alone, which is such a dangerous situation. And so it's just a godsend to have a whole team there to help stabilize our patients and let them know that we have their back and that we're going to help prevent them going back to the hospital. Try to make that critical follow-up with the PCP. We want them seen within the first, ideally 48 hours, but sometimes they can't get in for a week. So it's just a physician extender so that my patients stay stable at home, particularly the ones that can't get into my office now.